Good afternoon, everyone. At the outset, I would like to thank all the organizing committee for giving me an opportunity to stand in front of you. The topic given to me is minimal invasive pediatric cardiac procedures. So, disclosure before I start. This is not a lecture. This is just a watching like movie. So, I have put lot of animated videos. So, you can just relax and enjoy the videos. So, let's walk through the cath lab. Most common procedures what we do in cath lab is either we open the holes or we close the holes or we open the stenosed valves. So most common 5 procedures I have kept it here. First one is AHD device, VHD device and PDA device, and then opening of valves in the form of aortic valvuloplasty and pulmonary valvuloplasty. So before going through the procedures, I will just revise the cardiac anatomy. So heart consists of 2 sides. First one is a right side of the heart and the second one is the left side of the heart. Right side consists of right atrium, right ventricle and pulmonary artery, while left side consists of left atrium, left ventricle and aorta. Why it is necessary to understand cardiac anatomy? Because right side of heart consists of deoxygenated blood while left side consists of oxygenated blood. And there is a partitioning in between these 2 chambers, because if this blood mixes, then there is no point of having a heart. So we should have partitioning in the heart. So partition between right atrium and left atrium is known as atrial septum, and any defect in that septum is known as ASD, while septum between ventricular septum, right ventricle and left ventricle is called as ventricular septum, and any defect in this septum is known as ventricular septal defect. And we do have separate great arteries. First one is a main pulmonary artery and then aorta. So after this anatomy, I will just show you the first case, AHD device closure. So first I will show you the animation part, and then I am going to show you cath lab procedure in real. So how we see in cath lab. So this is the animation part. Looking at animation, don't think this is very easy to do it. So we are looking from the right side of the heart, and the first thing we saw is a atrial septal defect. And how do we do atrial septal defect device closure? So we need a venous access. Most of the time we prefer right femoral venous access. So this is a right femoral cannulation has been performed, and you can see the wire is going all the way from IVC right atrium across this ASD. Now we have entered on the left side of the heart, that is left atrium. This device is open. There are 2 discs for this device. The first disc is left atrial device and second one is a right atrial device. So I will just show you the device how it opens. So for that you need to see this one. So the device is already loaded in the short sheath. So if I push this cable, this device first disc will open. So first disc, this disc is known as left atrial disc, and the second disc, if we open, is a right atrial disc, and in between this portion is where the atrial septal defect is going to be. So unless you understand this one, you are not going to understand the next procedure. So when I need to load this device for the procedure, I just have to screw this device to this cable. So there is a screwing mechanism here, and I just have to pull this device inside the short sheath. So this is a loading technique. When I am deploying the device, I will just open the left portion first, and then when I am approximately at the septum, then I will open the right side. Then only it will approximate at the device position. So these are the 2 fluoroscopic images. So what we see in cath lab is only in 2 dimension. It is not 3-dimensional thing like in animation. So the first one is this portion of the device. So this portion of the device is in the right upper pulmonary vein. So this portion is left side of the device. So when we open the left side of the device, you can see this onion shape of the device. It is not completely open. So what we are going to do is, now I am going to open the right side, and when I open the right side, the device will fall back to its original position where it is expected to be. So this is how the atrial septal device closure is being performed. And once we confirm the position of the device by fluoroscopy as well as echocardiogram. So if it is younger patient, we do transthoracic echocardiogram. If it is an older patient, we do with a transesophageal echocardiography to confirm the position. And if we are sure that device is in position, then just you have to unscrew it. Just rotate the cable anti-clockwise. It will dislodge this device from this hub. So after dislodging, it will look like this in AP projection. So whenever you do X-ray for this patient in the future, you are supposed to see like this. If you are not able to see this device here, it means device has embolized and it is a major catastrophe. So the next common procedure what we do in cath lab is a VHD device closure. So for VSD device closure, we need two access. First one is a right femoral artery and right femoral vein. So this is a catheter which is advancing through the aorta, and that same catheter from abdominal aorta, thoracic aorta is coming all the way inside the aortic arch. And for this, we always make sure that catheter will follow the wire. So if you try to advance only catheter, it will going to pierce the blood vessel or heart, and there will be bleeding and child will die on the table. So this wire first we will cross. So this is aorta, left ventricle, VSD, and now we are inside the right ventricle. So this blue colored thing is a right ventricle, and this is a left ventricle, and this is a defect. So catheter is in place. So we park the catheter tip in the right ventricular outflow portion, and then we will advise the device as I showed you here. So the device is coming through the catheter. You can see this white thing. It is coming through the catheter. Now it has raised the left portion, then cross the VSD, and now device is on the right ventricular side. Now here we will open the right portion of the device first, then pull the whole assembly across the septum. It will touch the septum, and then only we will release the left side of the device, so that it will fit it perfectly. And once it is in position, then just unscrew it and release the device. So this is the most important step. Putting a device is not important. Making sure it is in place is important. Otherwise, device will embolize and it will be a major catastrophe, because this device can go to pulmonary, can go to aorta, can go to brain. Anywhere it can flow. So that is a major problem with these procedures. So how do we see in cath lab? So first image is a left ventricular angiogram. Normally, if you inject a contrast inside the left ventricle, you are not supposed to see right ventricle, because there is septum in between. But whenever there is a defect, so here is a defect. So when you inject a contrast here, because of defect, you can see the right ventricle as well. So this is a right ventricle, and this is aortic wall here. So this defect is just below the aortic wall. This defect is known as perimembranous ventricular septal defect. So this is a second image where we have crossed the defect with the wire. So this wire course is aorta, then aortic arch, aortic root, left ventricle, across the VSD inside the right ventricle. So first image, deployment of the right ventricular device. So this right ventricular device is being deployed here. So you can see here the right ventricular device is, portion of the device is already deploying, and now I am opening the left ventricular disc. So once both the devices are opened, we need to do angiogram. So first angiogram you have seen, when we injected the contrast, you were able to see both the ventricles. Now here you are able to see only the left ventricle. Nothing is coming to the right ventricle. It means the defect has been closed perfectly. So there is no residual lesion after the closure of this. So then only we will just unscrew this cable, remove everything. So these are the accessories we need to we need during this procedure. So after deployment, the device should look like this. And what we need to observe is whenever there is a cardiac beat, so device should move with the heart. It should not be like abnormal movement. So it should be in coordination. So if you look at the heart movement and device movement, it is synchronous movement. It means device is perfectly matched with the heart. Then the third most common procedure we do is a PDA device closure. As you all are aware, this is the only disease which is normal before life, and after life it is abnormal. So PDA is nothing but patent ductus arteriosus. So ductus arteriosus part is a normal during fetal life. It is mandatory, otherwise fetus won't survive. And after birth, it is supposed to close with the initial with the physiological closure by constriction, and then anatomical closure might take another 3 to 4 weeks. So if it remains open, what will happen? The aorta has a higher pressure. So red blood, that is oxygenated blood from aorta, is coming to pulmonary. So normal blood as well as this. So there will be excess blood coming to the pulmonary bed. And whenever there is excess blood coming to the lung bed, there will be heart failure. So PDA is the most common reason for heart failure in young neonate as well as young infants. So what we have to do? We have to close this. And nowadays all PDAs can be closed with the device closure. There is no need for the surgery. So for the same, we need two accesses. First one is a arterial axis, and the second one is a venous axis. Arterial axis we do need for angiography, because you need to delineate the defect. So this is a pigtail catheter used specifically for angios. So here in this angiogram you can see the contrast is being injected inside the aorta. So now you are supposed to see only aorta, because there is no normally there is no connection between aorta and pulmonary artery. But in this image you can see there is connection here, so which is marked in round. And now you can see this is a pulmonary artery. Even you can see the pulmonary wall here. So because of this connection you can see the pulmonary artery. It means there is a shunt, and you are injecting in aorta and seeing this one. It means flow is from aorta to pulmonary artery. So why we need angiography? just to see the defect size. So here you can see the defect size, you can see the defect shape and exact location of the defect, where is the defect. Second image is like we have crossed the defect from right side. So this catheter is coming from right atrium, right ventricle, pulmonary artery, and all the way we have entered through the PDA inside the pulmonary artery. This is aortic disc. We haven't opened the pulmonary, now we have opened the pulmonary end of the device. So how to confirm whether the position is in, the device is in correct position? You have to do aortic angiogram. The aortic angiogram will show that aorta there is no obstruction in the flow and there is nothing going to the pulmonary side. It means device is in good position, and now you just have to release the device with unscrewing mechanism. Another two important cases is just opening the valves. The first one is a pulmonary valvuloplasty and the second one is aortic valvuloplasty. For pulmonary valvuloplasty, I will just show you the animation part. So this is a pulmonary valve. It is a bicuspid. You can see two cusps. Normally it should be tri-leaflet valve, but this is an abnormal valve. There are only two leaflets. So this wire is coming from right ventricle to pulmonary artery, and over this is called as balloon catheter. So this balloon is now deflated. I will show you the NFAS view. So if you look at NFAS view, this is a bicuspid pulmonary valve and this is a balloon catheter. So this is the deflated balloon. You have to, now you see the valve area. This is a valve area which is very small. And once you inflate the balloon, now see the valve area. This is a quite big valve area. So this is how we do it. Just you have to put a balloon catheter across the pulmonary valve and inflate it. So in real, how do we see it? So first case I showed is a ASD that we do it in anterior posterior projection. Second one is a VSD that we do it in between projection between anterior and lateral, that is called as left anterior oblique, and this is a lateral projection. We use it for pulmonary valvuloplasty as well as PDA. So this one is a pulmonary angiogram. Catheter courses, it is coming from IVC, right atrium, right ventricle, and going all the way into the pulmonary artery, and contrast is injected in the pulmonary artery. You can see this doming thing is a pulmonary valve which is not opening correctly, and you can see pulmonary arteries are good. This is a main pulmonary artery and you can see right and left pulmonary artery. So second image is how we do the valvuloplasty as such. So this is a balloon catheter which has two markers. First marker is here and second marker is here. So whenever we position the balloon, we should make that this middle portion of valve, middle portion of balloon should be at the valve. And now you can see here. So at the time of inflation, the initial period, this part is quite tight. Rest of the balloon is inflated, but this portion needs some time. So this portion is known as waist of the balloon. Whenever waist is very tight, it means there will be narrow opening. So you need to take long time to inflate the balloon. So as long as it becomes a linear balloon structure, we have to inflate it. Second, another common case is balloon aortoplasty. It is same as a pulmonary valvuloplasty, but little bit difficult, because first valvuloplasty, what we are doing, we are going from right atrium, right ventricle, pulmonary artery. That is a natural course of a blood flow. But here in aortic, we are going from aorta. So we are going against the flow. Left ventricle is a high pressure system. It will inject the blood in the higher speed. So whenever you have to cross this system, it is very difficult to cross at first instance. And if you are successful to cross it, it is very difficult to hold that balloon in position. Otherwise, with the blood flow, that balloon will again jump into the aortic circulation. So what is another alternative we can do is we have to pace the heart. So this is a pacing cable. You can see this tip of a pacing cable is in an RV. So RV pacing we do when we are doing balloon aortic valvuloplasty. We pace the heart around 200 to 250. Whenever heart rate is high, your cardiac output will drop. And as cardiac output will drop, this balloon will stay in position, and that time we have to inflate. So this time is only 5 to 10 seconds you have to take it. Otherwise, longer duration of cardiac output drop, child will drop. So I'm just going to take you through cath lab scenario, how we see in the cath lab. This is 2 times faster video play. Don't think Rajnikant is doing the procedure. It is me who was doing the procedure. So this is securing the venous access, right femoral venous access. This is called a short sheath. So short sheath, we have to just put it in the right femoral vein. Why we do it right femoral? Because we are standing on the right side. It is very difficult to do it on the left. Because I'm right-handed, it is easy for me. So this wire is going from IVC, entered in the right atrium, across the defect into left atrium and pulmonary vein. So to take the device inside the heart, you need something longer structure. You cannot put the device through the shorter one. So we use this long sheath. So this is a device. I showed you the device, and now you need to load the device. I will take another half minute. So just loading the device on the cable. This is a cable loading on the short sheath. Now I am just going to exchange the short sheath with the long sheath so that that sheath will reach the heart. De-airing the system is very important, otherwise there will be air embolus and child will collapse because of air embolism. And you have to make sure there is no thrombus in the system. Otherwise thromboembolic phenomenon is very common because your catheter tip is in the LA and it will go to the systemic side. So now I am just passing that loaded device from short sheath into the long sheath, and device is now in the long sheath. And how do we deploy? So this is a long sheath which is all the way inside the left atrium. This is a device inside the long sheath. So this is so now I have opened the left atrial disc of the device and I am going to open the right one. So we will see the position of the device in different plane, make sure everything looks good, and this is a transesophageal probe which will help most of the situation to see whether the position is correct. So my take home point for minimal invasive procedures, it is as rewarding as an open heart surgery, but there is a added benefits. First benefit is a no or minimal blood loss. So you have seen the case and there was only one drop of a blood was lost and there are no blood products required as a transfusion as in open heart surgeries. Another important time, procedural time is less. So you have seen the video, it is just 2 times. So add another 10 to 15 minutes for preparation. So procedure from time for AHD device is around 15 minutes. Another most important thing is the overall cost of the procedure is much lesser than the open heart surgery. And duration of stay, most of the situation we are able to discharge the patient within first 24 hours of procedure. So it is very short time like daycare procedure. Another important thing is only sedation is enough in most of the cases. No need for general anesthesia. So far we have done 76 cases in Latur in last 1 year, and all those cases we had done under sedation. And the last and most important is that there is no scar for the lifetime as in open heart surgery. So this is very rewarding thing because this patient will not have psychological implication for the long term, especially in female patient, because these patients will be like very conscious about their cosmetics. And another major issue in our area is marriage problems. Thank you. If any questions, I am happy to answer the questions.
Thank you, Nitin Yelikar sir.